You, Professor. Thank you, Dr. Mushrod. Hi, my name is Lauren Chang. I am a professor and chair of social and behavioral sciences at NYU School of Global Public Health. It is my distinct pleasure to introduce Dr. Joseph Kirabira. Um, Dr. Kirabira is a psychiatrist and a public health specialist. He was born in central Uganda, and he has studied for a Bachelor of Medicine and Surgery and a Master of Medicine in Psychiatry at Mbarara University of Science and Technology. He's also completed a Master of Public Health at the University of Manchester in the UK and is currently undertaking doctoral studies at I'm going to get this wrong, Mbarara University of Science and Technology. He has already done quite a bit in his career. I'm going to, he's had several leadership positions. He's currently the chair of psychiatry at Busitema University, Faculty of Health Sciences. And his research mainly focuses on improving the mental health of children and adolescents with chronic medical conditions, such as epilepsy, HIV, and sickle cell disease. He's been an NIH Fogarty Fellow 3 times, most recently, and now with the Achieve Fellowship. He has worked under the mentorship, primary mentor, Dr. Yesim Tozan, and as well as myself, to pilot test a pediatric HIV disclosure intervention in Eastern Uganda. And so I'm very much looking forward to hearing about Dr. Kirabira's work. And with great delight, introduce him to all of you.
Yes, thank you. Thank you, Professor. I'm very delighted to be introduced by one of my good mentors. It's been nice meeting and working with you. And yes, like he has said, I'm a psychiatrist, and that means I do clinical work and teach. So my presentation today is about the mental health of children and adolescents with chronic illnesses. And I have been able to work with the Professor Yeshim and Lawrence because of the Achieve Fellowship Program. And so I'm very excited to present some of what we've been working on. So my research career is generally informed by the clinical work that I do and the teaching, which I also do. So it's usually from these two aspects that I get research ideas and see how to put them into practical research work. So I come from Uganda, and Uganda is one of the East African countries. It's a small country of about 93,000 square miles. And our recent population is about 46 millions. We have the diversity of tribes, we have many regions and religions, and these inform a lot of social culture background, which is very important for most of the research in our setting. Our healthcare system is twofold. We have public health facilities, which form about 45%, and the private health facilities. So most of the research that I'm going to present today is going on in the public health facilities, and some of it has already been conducted. So most of the research is usually in the public health facilities. Something unique about Uganda is the population that we have. Like you can see, this was a national census conducted last year, And you can see that the median age of the Ugandan population is about 15 years. So that means we have a very young population, and that is what keeps me very interested in the mental health of children and adolescents, knowing that majority of our people are actually young. So we have many chronic conditions, but I'm trying to highlight those that I have interest in, ones which I have personally worked on, and others for which I'm supervising students working in those areas. I started my research journey with epilepsy, and it is common in our setting to find that children tend to have higher prevalence of epilepsy compared to adults, meaning that there's a likelihood that many of them die off along the way because of different adversities. We have sickle cell, and in eastern Uganda, that's where we have the highest prevalence with I was just checking today with our sickle cell clinic, and the records show that we have about 1,700 children enrolled in the clinic, but with about 300 new cases this year that are yet to be fed into the system. I also have students who are doing research in diabetes, and the clinic shows that we have about 200 children with childhood diabetes mellitus. Cancer is a common chronic condition. I have a friend with whom we are trying to see how best to support children with the cancer, but from the Uganda Cancer Institute, based in Mulago, Kampala, 10% of the cancer cases they have are among children and adolescents. And last year they had a total of 770 new cases. Again, in eastern Uganda, we have a very high prevalence of heterogeneous albinism, and the association that brings together people with albinism is called SNOOPA. Their most recent records as per end of last year indicated that they had about 800 people with the albinism, though the specific proportion of children was unclear. So these are some of the chronic conditions we have in our setting, and the ones that I have definitely worked with or supervised students dealing with those conditions. So this presentation is mainly going to focus on HIV, and I will spend more time talking about HIV because that's what I'm dealing with right now. The common mental health challenges that we have found in most of these conditions are depression, anxiety, alcohol, and other substances being used. And then we have stigma and discrimination. So most of these conditions in general tend to have many of these disorders. Yes, so specific for HIV, I've been focusing on pediatric HIV, and in Uganda, as per the most recent records by the Uganda AIDS Commission, we have about 72,000 children and 85,000 adolescents who are living with HIV. And this is indicative of a reduction in the prevalence of HIV in this age group. That means that as we are having reduction in the prevalence, probably we now need to focus on how best to improve the lives of these children. So on the extreme right here, we have a graph that is trying to show the disclosure status according to age groups. And you can see children have the lowest disclosure rates, and they definitely have the lowest initiation to antiretroviral therapy, and the lowest viral suppression. So one of the most important things for pediatric HIV is actually HIV status disclosure, because many studies have indicated that it improves treatment outcomes, it improves adherence, it improves mental well-being. So we have guidelines by the World Health Organization, which have been adopted by our Ministry of Health to try and encourage or promote HIV status disclosure among children. And we usually expect children from 5 to 12 years to be undergoing disclosure or to have completed disclosure by the age of 12. But some of the studies that have been conducted among children in Eastern Uganda, the prevalence of disclosure was about 56 in one of the HIV clinics that I'm currently working with, and that was in 2015. However, it is important to note that 25 of these children were not correctly disclosed to. So there is a challenge with the misinformation and deception. So this was in Eastern Uganda, but we see the same trend even in southwestern Uganda. The second study was conducted in southwestern Uganda. So whereas we have non-disclosure as being a challenge, we even have a bigger challenge of deception to these children. Many of the studies have not necessarily focused on the mental well-being of these children in relation to disclosure. And that's what we have been trying to focus on for some time now. So what we are doing is conduct exploratory studies, try and establish the current disclosure status, the barriers and facilitators, the mental health of these children, and also review existing literature to see what other people have done. And from that, we have also been able to look at the guidelines that are existing in relation to disclosure and disclosure counseling. And we are now working on adaptation of some of the existing interventions. So this is what we have tried to do. And in all that work, I'll highlight two important projects that are currently ongoing, but very close to the finish line. The first project I've been working on is a project funded by NIH, which is focusing on building capacity in implementation science for non-communicable diseases. And in this project, we were basically assessing the mental health of children and adolescents with HIV and trying to look at the disclosure guidelines and how they are being implemented. So we have applied mixed methods, both quantitative, qualitative, and we have elements of implementation science. So we conducted a cross-sectional survey, which was assessing the mental disorders, looking at prevalence of disclosure and then prevalence of mental disorders among children and adolescents who are living with HIV. In this cross-sectional survey, we found that the disclosure prevalence was about 55, but we also found a 7.7% of misinformation, just like other studies have also found misinformation as existing in this population. The important finding that is a bit deviant from existing literature is that having a mental disorder was strongly associated with disclosure, with odds of about 2. And that means that probably in our setting, there are things that need to be put right, because we would have expected that disclosure should improve mental well-being. But in this context, we are seeing that disclosure is actually associated with having mental health challenges. And this table is trying to show the different prevalences. And you can see, generally speaking, depression, suicidality, generalized anxiety disorder, all these were more prevalent among people who had undergone disclosure, save for alcohol use disorder, where we only had for children and they had not been disclosed to. So we used the Mean International Neuropsychiatric Interview in all these assessments. And that pointed to an anomaly in our setting that is a bit different from what we are seeing in lots of literature. The qualitative interviews were conducted on only those children who had undergone disclosure, just to look at the experiences, things they go through, and how they are able to cope. And there were very many findings, but I just want to highlight HIV-related stigma. This was a very strong finding. Most of the children actually reported feeling more stigmatized the moment they get to know their HIV status. They start fearing that other people would know, or they already know, and it just worsens and affects their mental well-being. These were some of the coping mechanisms, and I just want to bring our attention to the non-health coping mechanism, which involved substance use. So we went ahead and explored the barriers and facilitators of disclosure. Most of the existing literature has looked at the caregiver perspective, but this time, knowing that we have guidelines that are meant to be used by healthcare workers, we decided to focus on healthcare workers to see the barriers and facilitators to disclosure in relation to the existing guidelines. And we used the combi model, and these are the different constructs and the associated barriers and facilitators for each. And I also just want to bring our attention to the training. Many health workers reported not to have sufficient training, and this consequently affected their knowledge and skills to conduct or support disclosure. But also, stigma still came up as a very important social barrier to disclosure. The other important facilitator that we noted was peer support, and this was at the level of healthcare worker to healthcare worker, then child to child, and then caregiver to caregiver. So there was a lot of peer support in the clinics, and it was important. So this is as per the combi model. We went ahead and tried to look at these factors as per the socio-ecological model to see at which level we have challenges. And I still want to highlight that stigma came out as a very important challenge, both at the individual level, interpersonal level, and the community level. So stigma still remained a very significant challenge to disclosure in our setting. And that prompted us to look at existing literature. So these are findings from the Uganda Demographic Health Survey that was conducted in 2022. And it found that stigma and discrimination is still a very serious issue towards people living with HIV. But I want to bring our attention to the stratification by regions. So we can see that women were facing more stigma, and they were trying to compare Kampala, which is our capital city in central Uganda, and other two regions which had the highest. And I want to mention that Bukedi and Elgon regions are all in eastern Uganda. So probably this explains why in most of our findings, stigma was a very important factor. So it means that in Uganda, the eastern region is actually having a very high prevalence of stigma and discriminatory attitudes towards people living with HIV, and it's one of the things that are affecting disclosure. So from those findings, we are now focusing on what we can do to address these challenges. So we either develop interventions or implementation strategies for the existing evidence-based interventions, so guidelines. For example, we already have the existing guidelines, so we may just need to develop intervention strategies. And because of that, we conducted a systematic review trying to look at the existing interventions for disclosure in low and middle income countries. And we came across 6, but I want to bring our attention to the second last down here, which was developed in Ghana. And this intervention was looking at training healthcare workers based on the existing WHO guidelines so that they can be able to support caregivers in the disclosure process. And we picked on that with a strategy of adapting it to our setting, but also task shifting. So what we have done with this intervention, knowing that one of the barriers was limited funding, which leads to limited staffing and many other things, we decided to adapt this intervention and see how best it can be used by non-medical personnel. So we have conducted an adaptation. We have made changes through conducting interviews and focus group discussions. And we are now trying to pilot this intervention to see whether we can train caregivers to support their fellow caregivers. So it is now a caregiver peer support disclosure intervention as versus to the healthcare work-based intervention. So this is what we did. We conducted qualitative interviews, FGDs and in-depth interviews, which we already finished. And now we are actually implementing the intervention. And this is the project I'm doing for the Achieve. So we used the CIFA framework, and these are some of the domains and how we looked at them. So after making the changes and now enrolling the caregiver peer supporters, we selected 4 caregiver peer supporters, and we were looking at those who have successfully disclosed to their children so that we can ride on their experience and give further training. So we trained 4 caregiver peer supporters and later supported them to conduct or support their fellow caregivers to disclose to their children. And we did that for 2 months, and now we withdrew the support supervision, and we have given them 2 months to see how they can do it on their own. So by the end of this month, we expect to conduct further assessments, post-intervention assessments. So the assessments we are doing generally rotate around how many children they have supported, how many have been successfully disclosed to, but we also go ahead and assess the mental health of the child and the mental health of the caregiver. And definitely we shall also conduct qualitative interviews for feasibility and acceptability to see whether we can push the intervention further. So the lessons we have learned from these HIV studies is that pediatric HIV status disclosure involves multiple stakeholders. You need a caregiver to support, you need a healthcare worker to support a caregiver, and then the caregiver discloses to the child. So meaning when we are designing interventions, it's important to factor in all those stakeholders. The age of a child is very important. It was one of the main barriers to disclosure, delayed disclosure. The more the child grows, the harder it gets to disclose, but also the culture and the physical and social environments are very important factors to consider when thinking about pediatric disclosure. However, we are now having a question of the role of HIV stigma, both for disclosure and mental illness. So we are trying to think about how the role and how best we can address the HIV stigma and discrimination. Because whatever we've been doing, we were not primarily focusing on HIV stigma, but it has come out to be a very important factor in the disclosure process and pathophysiology of the mental disorders. But we are also looking at the possible most effective intervention or implementation strategy, for example, for the guidelines that can promote both disclosure and mental well-being of the children. So what we have appreciated over time is that children and adolescents with chronic illnesses have a high risk of getting mental health challenges. However, the factors for the different chronic illnesses may be unique, but also related. For example, we have conditions like epilepsy, sickle cell, cancer, which are also equally stigmatized. So whereas there can be other unique factors to the different disorders, we think that from the lessons we have picked from HIV, some of these factors can be related, and so we need to factor them in. When we are looking at chronic medical conditions, we are also looking at the intersectionality of stigma, whereby you have a stigmatized medical condition, and then you're also developing mental illness, which is equally stigmatized. So we are trying to look at the intersectionality of this stigma in these chronic conditions. However, we still have a number of gaps, even in basic exploratory studies. For example, many of these other chronic conditions do not have even the prevalences of mental conditions. It's just students that are coming up to pick interest in the different conditions. So we lack basic information. There are not so many interventions, especially those geared towards mental health challenges, and implementation research is still a new aspect, but we see its applicability in areas where we have some evidence-based intervention or guidelines, which may just need developing context-specific implementation strategies. Then we are also trying to look at the role of technology. There is a lot to do with the AI, for example. How best can it be applied to our setting? So whereas we have many research gaps and there is a clear reflection of healthy disparities with limited evidence-based interventions, I want to mention that Uganda provides a research-friendly environment. We have a number of, for example, ethical review committees. The public health facilities are very good for studies, and participants are very welcoming. So the research environment is very friendly, and it provides a conducive, collaborative, and multidisciplinary environment where we can do a lot of research and try to address these challenges collaboratively. So that is the end. Thank you so much for listening in, and we can have discussions here and there. Thank you.
Great. Thank you so much. A reminder to everyone in attendance, please put questions into the Q&A box, and I will kind of try to summarize them and then pose them to our speaker. So there's a kind of multi-part question, which I'll try to break into pieces one at a time for you. So first is, wondering if you could talk a little bit about stigma, and this may be like a definition issue or a measurement issue, but was this like perceived stigma? Was it measured as sort of actual experienced stigma? Can you talk a little bit about that, please?
Yes, thank you. So we assessed stigma in two ways. For the cross-sectional study, we actually applied this AIDS internalized stigma scale. It's what we used to quantitatively measure stigma, though I have not included that information here. But yes, when we were doing a cross-sectional survey, we assessed stigma quantitatively using that questionnaire. And what I'm reporting here as experiences was assessed qualitatively. So these were qualitative interviews. And like we can see here as part of barriers and facilitators, we had internalized stigma at an individual level and also anticipated stigma at both individual and interpersonal level. And we had the actual discrimination or enacted stigma at a community level. So these were reported by healthcare workers. What I'm trying to highlight here is that depending on the study objective, stigma was assessed either using a questionnaire quantitatively as per the cross-sectional survey here, though I didn't include the results. And from the regression, stigma was only significantly associated with generalized anxiety disorder. So there was no significant association between major depression, suicidality, and stigma. It was only significantly associated with generalized anxiety disorder, and that was the quantitative component. The rest, it was qualitative, and we looked at it either as enacted or anticipated or internalized.
Great, thank you. While we're on the topic of measuring stigma, a question about the regional differences in stigma that you presented. If you could talk a little bit more about why, or if we know anything about why there's differences across parts of Uganda in terms of stigma.
Yes, so like we can see down here, according to this survey, for example, in men, education was an important factor. So those with the higher education were less likely to be discriminated. And then we can see that with women, socioeconomic status was one of the factors. And when we look at the eastern region, it's one of the poorest regions in the country, actually. And definitely poverty moves hand in hand with the low socioeconomic status. So the distribution of wealth in Uganda is more in the central, and then some parts of southwestern Uganda, but parts like eastern Uganda, the northern Uganda, where we had a war for a long time, those are the poorest regions in the country. So I think these two factors highlighted in this survey can still explain this, but I also believe there are social cultural underpinnings beyond these factors, the belief systems of the different regions. When we say Bukedi region, it means we have a different tribal group there altogether. Elgon, a different tribal group. So these are different social cultural contexts.
Great, thanks. Also a question, you mentioned a couple of different theoretical frameworks in this talk, including the socioecological model and the COMBI. A question about sort of why use two frameworks, and I'll add to that, are there kind of synergies between the frameworks and how do you see them influencing your work?
Yeah, so when we were setting out, we wanted to actually look at the barriers and facilitators using the COMBI model. And actually, this is the model that informed our interview guide. So the questions were designed in line with the psychological ability, like the different constructs we have here. And when we got the results, they were so interesting that one of the supervisors suggested that we could actually use the socio-ecological model to see at what level we have what problem or what barrier or what facilitator, so that when we out there talking, for example, when you go to the healthy policy makers, you can know that at that level, probably you want to discuss issues of funding and providing guidelines. But when you come to the health facility, you may just want to see that they put some pre-disclosure preparatory procedures, they train their healthcare workers. So basically, this COMBI model informed the designing of the interview guide, and part of the analysis. The socio-ecological model was used mainly to categorize these barriers and facilitators for communication purposes, but the main model was COMBI.
Great, thank you. Last part of that question was, you mentioned a decrease in, I guess, prevalence of HIV among young people. And just there was a question about, can you talk a little bit more about that, particularly given, yeah, here we go, particularly sort of given performance on the cascade indicators, why do we think cases are declining among young people? Thanks.
Yes, thank you. And actually, when we look at the last two categories here critically, you can see that for children aged 0 to 14 years, we have a decrease of almost half. We had 140,000, that was 13 years back, and 13 years later, it was almost half. But the decrease for adolescents 10 to 19 was not as high. But what I can explain here is that the government has put in place very intensive EMTCT, elimination of mother-to-child transmission. And for pediatric HIV, that is the commonest route. So there are very many efforts in place to implement that, and that explains the significant drop in the cases at this point. But when you look at the indicators, because this means we already have these children in the community, from the age of like 5, we would expect parents to start informing their children that they have HIV. So probably we have those above 5, below 5 being counted here. So probably it explains the slightly low disclosure rate, but also the non-disclosure among children explains why we have a lot of challenges with the, for example, viral suppression. In most of the clinics, HIV clinics, they tend to query disclosure status after seeing a child who is failing to achieve viral suppression. So usually when a child is not achieving viral suppression and is above 5 years or 10 or 12, or sometimes we even have those who are 16, but they do not know, then that's when the healthcare workers tend to handle disclosure more aggressively. So non-disclosure can potentially explain why we have lower viral load suppression among children compared to other populations. But the reduction in the absolute numbers of prevalence is because of the PMTCT and EMTCT programs that are countrywide.
Great, thank you. I'm going to read this next question verbatim because there's a lot in here and I don't want to miscapture it. So thank you for this important work. Most of our tools for addressing pediatric mental health are based on the assumption that a child has suffered a trauma or has a pathological condition like anxiety. You've done a really nice job describing the problem of mental health related to a hidden factor, i.e. disclosure. Do you have thoughts about treatment besides the event of disclosure itself? Is ongoing mental health screening or support by a pediatrician useful? Are there ways to provide support to children without disclosure in ways that maintain the family's desire not to disclose, or to support the family and the child's mental health over a long time while they consider disclosure? So I guess I would summarize it by saying, given how important disclosure seems to be, what are our intervention options besides disclosure? What other things could we think about doing if people maybe aren't ready to disclose, or are there complementary activities? Thanks.
Thanks for that important question. And I also want to mention that currently in HIV clinics, there has been enrolled a program where there is routine assessment of mental health of most of the clients, but I'll specifically mention children and adolescents for this case. So healthcare workers are being trained and provided with brief questionnaires they can use to assess mainly for depression and anxiety. And that is being implemented in some of the clinics. So as we are discussing some of these findings, what we are also looking at is how best we can actually support this screening process. However, like the person has stated, it is a temporary solution because that means the underlying problem is disclosure. So that's why we are trying to see, yes, as we are screening, how best can we also encourage the caregiver to disclose? Because by standard guidelines, the caregiver must be ready to disclose. And that's why it makes some children stay for very long without knowing, because the caregivers have their fears and worries and they don't want to inform the child. So there is ongoing screening being implemented in the HIV clinics for depression and anxiety mainly, but we are also saying how best can we support the screening process, but also come up with a way which can make caregivers find it much easier to disclose so that we address the root cause.
Great, thank you. Back to measurement. So another question about measuring the mental health related outcomes among children. If you could talk a little bit about the age range of the children, the tools that you used, which conditions you were interested in, around measuring the mental health outcomes in this group. Thanks.
Yes, so we were looking at children who were aged 8 to up to 17 for the cross-sectional survey. Yes, so here we were looking at children aged 8 to 17. We used the mini international neuropsychiatric interview for children, all the mini kids. I think we have a 7th version, which is based on DSM-5. DSM-5 is the Diagnostic and Statistical Manual. So we preferred that because that is very close to the actual diagnosis that we actually use in diagnosing these conditions. So we used that to assess major depression. It has a module for a major depressive episode. It has an extensive assessment of suicidality with very many questions, and it also assesses generalized anxiety disorder alongside other anxiety disorders, but we only did this. It also assesses alcohol use disorder. So the only condition we assessed, and we didn't use the mini kid, was stigma, because it does not have a stigma scale. But like I said, we use the internalized AIDS-related stigma scale to assess stigma for this survey, and then qualitatively through interviews.
Great, thank you. We also got a question about whether there's any way of screening or, like, I guess, latent factors that may be associated with early disclosure. So other things that we could maybe measure or proxy in order to predict who might be more likely to disclose or not. And then, well, I'll let you answer that, and then I'll move on to the second half of the question.
Yes, thank you. We assessed a number of factors, both social demographic and clinical, but I want to highlight that the most important factor that we found cross-cutting for disclosure was actually age. And I think it is because the older the child gets, the higher the likelihood of being disclosed to. So younger children were less likely to know. Older children were more likely to know. On the other hand, increasing age was also associated with a higher risk of getting a mental disorder. So that means when we have delayed disclosure, the child is more likely to struggle with this information when they get it, and the risk of breaking down is higher. And of course, now adolescence comes with its own challenges. So the recommendation from that would be to start the process early and make sure that it's completed by the age of 12 as per the WHO and Ministry of Health guidelines. So age was one of the important factors that was cross-cutting for both mental disorders and disclosure.
Great, thank you. And then second half of this question was, are there factors or things that could be done to help equip a child to handle their newly disclosed zero status?
I think that can best be explained, and that's why we try to look at the coping mechanisms, and we classified these into healthy coping mechanisms and the non-healthy. So we learned from the interviews that many of these children, when they get to know their HIV status and they have undergone good counseling, which is one of the ways they can be supported, they tend to stick to their treatment because it gives them hope that when I swallow my medicine well, I have a possibility of living as a normal person. And that came out very prominently in most of the interviews. So adherence was a common coping mechanism because it provided some ray of hope to these children that, yes, I have HIV, but when I take my medicine, the doctor has said I'm likely to live as a normal person. But some of these children reported distraction. Some would choose not to think about it. Others would go put their attention to several other things. We have social support, those children who, when they get to know their sterile status, they get more support or they seek more social support. They had better coping compared to others, but we also had things to do like with cognitive restructuring. Many of our, like I said initially, in our setting, religion is a very strong thing. So many of these children would turn to God, they would start praying so hard. And now the challenge we usually get in mental health with the religion is when someone defies biomedical treatment for prayer. But yes, in these children, we had a number of them who would stick to their treatment, but now they go and start praying and it helps them to cope. So I think generally speaking, in our setting, social support, emotional support are very important. Intensive counseling after disclosure is also very important, and encouraging adherence is very important. Those were important coping mechanisms for these children.
Great, thank you. And then probably our last question, if you could go back to the slide with Combi on the left. A question about sort of this one, about sort of using Combi and whether you think there's, or whether you would be open to other frameworks and other measures. I know this was sort of specifically about healthcare workers' attitudes around disclosure, but just generally speaking, if you have sort of interest and willingness to use other measures, emotional, psychosocial measures for these topics. Thanks.
Sure, actually, that is very welcome. It's I think this is the first such study, so we have so much room for applying many other ways of trying to understand these concepts and then probably inform interventions better. So I think that is very, very welcome.
Great, thanks. That's a wonderful note to end on. So thank you so much for this really terrific presentation. I think the number of questions you got and the richness of the discussion really speak to how relevant, applicable, and important your work is. So thank you for sharing it with us and spending time with us. Really appreciate you and all that you do. Thank you very much. And thanks, everyone. Reminder, the next of these on March 31st. Hope to see many of you there. Take care. Bye-bye.